Assalamu alaikum wa rahmatullahi wa barakatuh. It gives me a great pleasure to introduce you to this important session on adult pneumococcal vaccination. And that's going to be delivered by our colleague, Dr. Naim Aoun. Dr. Naim Aoun is Chief of Medicine at the American Hospital, Dubai. He is by training consultant pulmonologist and critical care medicine, and he also carries a certification in sleep medicine. He's currently working in Dubai, and we are honored to have him give us this talk on an important session. As much as we're talking about COVID-19 vaccination, other vaccinations such as pneumococcal vaccination remain an important practice for us in internal medicine. And I wish you an informative time with Dr. Aoun. Thank you very much, Dr. Aoun. The floor is yours.
Good evening, everybody, and thank you for having me tonight. So this is Dr. Naim Aoun. I'm a consultant in pulmonary critical care and sleep medicine at the American Hospital of Dubai. I'm here today to talk a little bit about adult pneumococcal vaccination for at-risk adults and a small overview about community-acquired pneumonia. So let's get started. First of all, let me define a little bit the Streptococci genus/species, just to make things clear. So Streptococci is a gram-positive, as you all know. Usually you find them in pairs and chains. You have the family of the beta hemolyticus. The well-known is group A, that causes the soft tissue infections, the toxic shock syndrome. And then you have the other species, as you can see below, where Streptococcus pneumonia is. Streptococcus pneumonia responsible for pneumonia, meningitis, etc., as we will see in a bit. Enterococci used to be in the family of Streptococci, but now they diverged them into a family on their own. So, having said that, our interest today is in Streptococcus pneumonia, which is the bacterium responsible for pneumococcal disease. So first of all, it's a leading cause of pneumonia, meningitis, and bacteremia worldwide. The organism has an outer polysaccharide layer. This is what defines the stereotypes, the 90 different stereotypes. This is antigenicity difference is there. It functions as a virulence factor and is the vaccine target. Of course, nowadays with the pandemic going on, this reminds us of the virus we've been dealing with, the coronavirus. So there are some similarities in the physiology there. We have more than 90 serotypes of Streptococcus pneumonia, which have been identified. They are not all equally pathogenic. Some of them are more pathogenic than others, and that's why the vaccinations we're going to be talking about target some serotypes versus the others. Anti-resistance to Streptococcus pneumonia has been a growing concern worldwide. And interestingly, it's an exclusively human pathogen, commonly carried in the nasopharynx. So it's a disease of humans and we don't share it with any other species or animals. So first of all, the pneumococcal strain establishes itself in the nasopharynx of a host. Then from there, it can migrate to cause otitis media, to cause the dreaded meningitis. It can cause bacteremia, can cause pneumonia, and from this host, we can have a transmission of the pneumococcus to other individuals, and that's how it becomes contagious. So, pneumococcal disease can be divided into two families, the invasive and the non-invasive, which we call mucosal, meaning acute otitis media, sinusitis, and 75% of pneumonias are called mucosal, meaning it's not breaching this barrier and going into the blood to cause bacteremia. 25% of pneumonias, however, are invasive and can cause a bacteremia. So, and then another form of invasive infection is, of course, bacteremia without a pneumonia in its own right, which is by definition an invasive condition, and the meningitis, which is also considered invasive. Pneumococcal disease presents differently between children and adults, so it's not the same disease we encounter. For example, as you can see here on the right-hand side, meningitis is still in adults, bacteremia is in adults, bacteremic pneumonia is in adults in 25% of cases, as we just said, but 75% are non-bacteremic. In kids, it's more the otitis media, pneumonia, and the bacteremia sepsis, but to definitely a less and lower extent. Let me talk a little bit here about community-acquired pneumonia. So as you know, lower respiratory infections, including pneumonia, are among the top 10 causes of death, according to the World Health Organization. Reported incidences of community-acquired pneumonia in developed countries range from 1 to 11 per 1,000 individuals per year in the adult population. It's the most important cause of mortality from infection in adults. You know, you have cardiovascular disease, cancers, etc., that precedes it. But among all infections, pneumonia is the most common cause of death. While in children, unfortunately, community-acquired pneumonia is the leading cause of death worldwide. In pneumonia, the hospitalization rate can vary from 20 to 40% in adults. And Streptococcus pneumonia is the most common causative agent of community-acquired pneumonia, accounting to, depending on the studies you look at, 7.5 and up to 30% of the pneumonias. So, how does it work? Infection progresses through colonization of the upper respiratory tract. So again, the entry is through the upper airways, where Streptococcus pneumonia is part of the bacterial flora. Asymptomatic carriage of pneumococci usually lasts weeks to months and does not necessarily lead to infection. So not everybody who has it in their throat will have an infection, and this is even more common in children. There's an inverse relationship between duration of carriage and infection rate of Streptococcus pneumonia serotypes, meaning the longer those kids will have it, the less likely it is for them to have an infection from it. But of course, they are more likely to transmit it to somebody else, their parents, their grandparents, or their peers at school. So again, prevalence of carriage is age dependent. So prevalence rates in developed countries are highest in young children from 24 to 70%, and they decrease in older children and adults 8% to 22%. This is an important point because it will explain why targeting through vaccination children is important. And again, goes back to the current pandemic vocabulary that everybody learned, talking about herd immunity. So that's how we reach it, by targeting those kids to prevent them from infecting their parents and grandparents, etc. Now, the IPD is invasive pneumococcal disease. Risk of IPD is highest in the youngest and oldest age groups. So once it's pneumonia, for it to become bacteremic, for it to become invasive, the risk is higher in the elderly population and in the very young population, as you can see. And those two charts show us a difference, how actually it's not different, similarities between what we noted in 2015 in the US and in England between 2013 and 2014. Again, emphasis on why we vaccinate the young and why we vaccinate the elderly, because those are the two most susceptible populations. Invasive pneumococcal disease is when Streptococcus pneumonia is isolated in a sterile body fluid. It's the greatest, as I just said, in young children and in elderly patients, but also in patients with chronic comorbid conditions, such as chronic liver disease, COPD, or people who are immunocompromised. Again, we're gonna see all this later on when we're seeing who are we targeting with vaccination, who are our candidate vaccine recipients. Mortality is very high in IPD, 3% in children and 18% in adults. However, fortunately, and since there was an introduction of in national immunization programs worldwide for pneumococcal vaccination, there was a decrease in the mortality in the adult population. So this brings me to the available pneumococcal vaccines for adults. Two vaccines are currently available for pneumococcal vaccinations. We have the polysaccharide, which is the PPV23. This one has 23 valent pneumococcal polysaccharide vaccine, meaning it's targeting 23 serotypes of those 90 we mentioned. Those are the 23 most virulent ones, the ones that were discovered to be the most common causes for infections among children and adults. And then we have the second generation vaccine, which is the conjugate. This is the PCV13, pneumococcal 13 valent conjugate vaccine. This one is targeting 13 very virulent pneumococci. There is an overlap between the serotypes we cover in the 13 and the 23, of course. Although comparative immunogenicity trials have been conducted with PPV23 and PCV13, there is no head-to-head efficacy data to say one is better than the other when it comes to efficacy. So, since they introduced the vaccination, and this again going back to the herd immunity theory, since they introduced the vaccination for the youngsters, and again also for the adults as of 1984, we started noticing a significant decline in cases per 100,000, for example, of all invasive pneumococcal disease. This one is in orange, and also, and look how it goes in parallel, of the 23 types in green and the 13 types. So we really did a very good job over the last 20 years, 30 years in vaccination, and look at the IPD ratio, which is going down. And as I said above, also it translated in lower mortality, mainly in the adult population. Let us look at the PCV13 efficacy and effectiveness in adults. So, as we said earlier, community-acquired pneumonia and pneumococcal pneumonia severity is influenced by host and environmental factors. So, host factors, less than 2 years old, more than 65 years old. At risk, people with chronic heart disease, COPD, asthma, diabetes, functional or anatomic asplenia, chronic liver disease, CSF leaks. Those are people at risk. You have also, of course, the people at high risk with HIV infection, chronic kidney disease, solid hematological cancers, solid organ transplantation, obviously, autoimmune diseases, people on immunosuppressive therapy, no matter which one it is, or corticosteroids, people with primary immune deficiencies. Also, what do we have as environmental factors? Preceding viral infection, notably influenza, will increase the risk of pneumococcal infection down the line. Now, maybe the question arises, how about COVID-19? I don't think we still have enough data. Currently, we have not seen a resurgence of pneumococcal infections or any other bacterial infections / pneumonias post-COVID-19, but the jury, of course, is still out, still early in the courses. Now, residence in an institution, such as a nursing home, also increases your risk because of the close proximity. And as you saw in the United States, for example, COVID-19 did ravages in nursing homes. Behavioral factors, smoking, alcohol abuse, current opioid use, all of this puts you at higher risk to have a pneumococcal infection or a severe one. This is the study that the landmark study came out in 2015. We call it the CAPITA study, which is the community-acquired pneumonia immunization trial in adults. Okay, this is the one that looked at the PCV13 and its efficacy. We will review the study in a brief way. Study enrollment criteria: they enrolled male or female who are 65 years of age or older, registered with the GP, able to fulfill the study requirement. So they exclude them if they ever had a previous pneumococcal vaccination, obviously if they had PPV23, because this one, the one available, use of investigational vaccine or medication in last 30 days, if they were residents in nursing home, long-term facility, immune deficiency or suppression, history of severe adverse reaction, a contraindication to influenza vaccination if influenza vaccine is to be administered at the same time, or contraindication to PCV13. The study was actually done in the Netherlands, okay? So they used a standardized approach for identifying study subjects, presenting with clinical suspicion of community-acquired pneumonia at the emergency department or the other 58 sentinel hospitals. They did a diagnostic workup, including chest X-ray, blood culture, and urine sample. And then they defined community-acquired pneumonia, if they had it or not, based on protocol-defined clinical criteria and X-ray findings consistent with pneumonia. So we are looking here at how they defined pneumonia in patients who they suspected they have it. So at baseline characteristics, as you can see, there was really a matching between the placebo arm and the recipients of the PCV13. It was quite a large study. We're looking at around 42,000 in each arm. The average age was 72 years old, 55% of them were male, 44 female, and then a lot of them as well had some comorbidities, which is important to enroll so we can look at all kind of real life scenarios. So we had 5% of people with asthma, we had 3% of people with diabetes, with insulin use, but almost 10% with diabetes without. A quarter of them had heart disease, few had liver disease, lung disease in 10%, and smoking in 12%. So it was quite inclusive, really mimicking patients we see in real life, patients we see in our clinics on a daily basis. How did they define primary and secondary endpoints? Again, confirmed viral vaccine type pneumococcal CAP, presence or two of more specified clinical findings, which is consistent with community-acquired pneumonia, plus an X-ray and cultures of vaccine type Streptococcus pneumonia in a sterile site. There is confirmed pneumococcal CIP, again, presence of two or more specified clinical finding consistent with CAP with a chest X-ray, and confirmed viral vaccine type pneumococcal community-acquired pneumonia by another kind of assay for which a blood culture result is available and is negative, and for which any other culture results from pleural fluid or other sterile sites are negative. And finally, they defined, of course, vaccine type invasive disease where the blood cultures were actually positive. So primary and secondary endpoints per protocol population. So here we can look at the vaccine group. First episode of confirms, again, vaccine type. So they were very specific looking at if those serotypes cause the infections or not. So they had 49, for example, in the PCV13 and 90 in the placebo. The difference is 45% with a good interval. First episode of confirmed pneumococcal community-acquired pneumonia, 33 versus 60. Again, protection of 45% with excellent confidence interval and a strong p-value. And infection, an invasive pneumococcal disease, only 7 in the PCV13 group versus 28, and this is where we see the most protection, up to 75% with an excellent confidence interval and an excellent p-value. So this is consistent as statistically significant reduction in first episode of vaccine type pneumococcal community-acquired pneumonia, and most importantly, invasive pneumococcal disease with the PCV13 vaccine. So again, primary endpoint, 46% reduction of the first episode of pneumococcal pneumonia, 45% reduction in prevention of first episodes of vaccine type non-bacteremic, non-invasive pneumococcal community-acquired pneumonia, and 75% of the invasive pneumococcal disease. So those are statistically significant numbers. Side effects were not really far from the placebo when it comes to the most important. However, as we can expect, we had some local side effects like redness, swelling. Those were quite different from the placebo, and pain on site of infection, limitation of arm movement. But as we go down the line, we notice that they rematch, except for some new generalized muscle pain, which was a little bit higher in the vaccinated group versus the placebo. Looking at side effects or adverse events from the vaccination, we look at the table here and we notice that there were few differences between the vaccinated population and the placebo group, all within the expected range, like redness on the site of injection or swelling, pain on injection, limitation of the arm movement. This is where we see the major differences. It's slightly bit more fatigue in the vaccinated group versus the placebo group. And also one slightly significant difference is the new generalized muscle pain in the PCV group was like 10% higher than the placebo group, but otherwise, as you can see, the differences were not that significant. Summary of adverse events post-vaccination with the vaccine. So this is, we're looking at within 1 month of vaccination, subjects who reported serious adverse events were 0.8%, basically 327 out of the 40,000, not too far from the placebo, where we had 0.7% reporting of serious adverse events for 314 total numbers. Within 6 months of vaccination, subjects reporting serious adverse events was 70 versus placebo, where it was recorded to be 60. So during the follow-up period for case accumulation, up to 4 years, there were 3,000 deaths, 7.1% in the PCV13 group, and 3,005, 7.1% in the placebo group, which is exactly the same. These data do not provide, obviously, any evidence of causal relationship between deaths and vaccination with pneumococcal 13. So there was no difference in mortality at all, and the numbers were exactly the same. Adults at risk for pneumococcal disease. So let's look at some post hoc analysis where we can see that there was similar immunogenicity which was observed in a post hoc analysis 1 month after the vaccination for adults at risk versus those not at risk. At risk meaning they have comorbidities that could put them at higher risk than their patient from the same age. So here we can see that the immunogenicity was very similar whether patients were at risk or not, meaning that even if they had comorbidities, cardiovascular, pulmonary, etc., the immunogenicity at 1 month did not change. Looking forward at other post hoc analysis where they compared immunogenicity in adults aged 18 to 64 years old with underlying medical conditions and adults over 65 years old. So here they pooled several studies, including the one we just reviewed, which is the Capita from the Netherlands, including 2 other studies from the United States. We look at PCV13 at dose 1, and then we look at, for example, the Capita study, it including 444 patients at risk, 518 patients without risk. The other study was also done on patients 60 to 64-year-old. It included 470 patients at risk at this age bracket. 470 patients, 165 of them were considered at risk within this age bracket and 305 without. And also another study that included 1,673 younger population, 18 to 64 years old. And here we had 500 patients at risk, 1,174 not at risk. So here immunogenicity was assessed at 1 month after vaccination, and it showed that there was no difference in between patients who are at risk, no matter what the age is, and patients who were not. So again, here we are looking at it with underlying medical conditions, comparing patient adult compared to one at higher, older than 65. And those are the different serotypes that we are targeting with the PCV13 to make the scheme easier to understand and summarize it. Again, there was an excellent immunogenicity, no matter what age, no matter what risk factor we are including, to all the serotypes that were included in the PCV13 vaccination. Again, some post hoc analysis looking at the efficacy by stratification of participants in the Capita trial based on their at-risk status, which we defined earlier. Again, to make it simple, there was no real difference in the immunogenicity between those populations. Another way to look at it. So again, here we are looking at the entire population, patient at risk and patient without risk, and also the lack of difference and the same level of protection that we saw earlier, whether they were at risk or not. So the duration of protection. So this is an important slide here to underline the differences between the 2 kinds of vaccines we have on the market. So conjugation of polysaccharide to a protein carrier can elicit a T-cell dependent immune response. So basically, that's why we call it a PCV. Like pneumococcal conjugated, because the antigen is not taken alone, it's conjugated to a protein carrier that makes it more immunogenic. So we will have a better response. So if you take a polysaccharide vaccine alone, which contains the polysaccharide antigen from the wall of the bacteria, it will only elicit a T-cell independent immune response. So basically, we are going to stimulate the B cells to produce antibodies. And those antibodies we are dependent on to have in protection. Again, it's so consistent with what we've been dealing with lately and all the talk about vaccination. While conjugated vaccines, where we're going to attach those antigens to a protein carrier, will make them more immunogenic. So we have the polysaccharide, but also covalently linked to a protein carrier. This is going to induce a T-cell dependent immune response, which is going to stimulate not only the B cells to produce the antibodies, but also to T cells, which are going to give an immune memory. This is what we call the memory T cell. So down the line, even if the antibody level is down, the moment our body is faced with the bacteria or perhaps with the virus, we're going to have the memory cells waking up and re-stimulating the production of antibodies. And this is why one theoretically vaccine could be considered stronger than the other. So this is the CAPITA study again, and we're looking at how long did the protection last after the vaccination. And as you can see here, that the protection, so this is the cumulative number of episodes, going all the way to 4 years, was still significant as the years went by when it comes to PCV13 versus placebo. And again, we all hope that we'll see the same charts when it comes to COVID-19 vaccinations. Again, there was no waning efficacy observed. Here we are looking at cumulative numbers and episodes of non-bacterial, non-invasive vaccine-type community-acquired pneumonia. Again, going at 3.5 years, 4 years, we're still seeing the cumulative number of the infection go up, while in patients on placebo, while patients who were protected are still being protected to the same degree of protection. Here we're talking about cumulative episodes of invasive pneumococcal disease. Also, they noted that the protection lasted for the whole 4 years of follow-up on those patients. So if the sequential use of PCV13 and PPV23 is considered appropriate, which vaccine should we administer first? A very common question we get all the time. So this chart answers it. When we give PCV13 first, it enhances the response to a subsequent dose of PPV23 at 1 year interval versus giving the PPV23 alone. And of course, we here are looking at the serotypes included in the PCV13 and overlapping with those serotypes from the PPV23. We are looking at immunogenicity on the right-hand side. We're looking at giving PPV23 alone versus giving it 1 year after having given the PCV13. And we can see that when it comes to all these serotypes, there's a significant immunogenic response versus having only one of them at 1 year time. So that's why we recommend, if we have to give both, to always give the PCV13 first and 1 year later, the PPV23. Clinical studies of sequential vaccination support administration of PCV13 as well. Again, this is here, we're looking at the immunogenicity levels, and we notice that there was a significant improvement, whether it was given before or without or after PCV13 administration. So worldwide public government pneumococcal recommendation and reimbursement for adults. So adult vaccination with PCV13 is recommended now in over 50 countries worldwide, and this is as of recent as January 2020. National public recommendation for PCV23 also for a different kind of patients at risk. So for high risk, at risk and high risk, or for age plus high risk consideration. Also, each country has its different rules worldwide. If we look at Dubai, for example, the DHA has released a circular recommending PCV13 vaccine for adult patients with specific risk factors. For example, here they recommend age 19 years and above who are at risk or with high risk should be vaccinated. Any healthcare provider, regardless of age, so most of us are included, patients or individuals going to Hajj and Umrah, people with diabetes, chronic cardiovascular disease, chronic pulmonary disease, liver disease, or bronchial asthma, and of course, all the others that we discussed earlier, such as CSF leak, a history of immune suppression, cancer patients on chemotherapy, etc. There is recommendation to be vaccinated. And they specify that there are two types of pneumococcal vaccine. The unavailability of one of these vaccines should not defer the use of the other vaccine. So this is their schedule and the recommendation, which is also to provide the PCV13 initially, wait 1 year, then give the PPSV23. After 5 years, the PPSV23 can be repeated. So this leaflet is very helpful. I keep it in my office and use it as a reference when we want to vaccinate patients. But there are some intricacies. We don't assume to memorize it all the time, and this is why I said I have it handy and available for me, so I can refer to it whenever I would decide about vaccination. The interesting part is also that it's more liberal than some other countries. All adults aged 50 years and above should receive the following: PCV13 initially, if they have never received a vaccine before, and then after 1 year receive the PPSV23. For those who have previously received one dose of 23 at the age of 50 or above and did not receive PCV13 before, this should be followed after an estimated year by PCV13, because they consider that some people could have received the 23 beforehand. For example, if we look at this one here, for those who have received one dose of PCV13 and did not receive PPS23, again, they recommend waiting 1 year, vaccinating the first dose, and again, 5 years later, and then giving them the second dose, and after age 50, one more time. So there's a clear guidelines in Dubai about who to vaccinate. So we hope honestly to see a pickup in the ratio of vaccination with this very important vaccine that can lead to significant benefits to our patients. And that will be the end of the talk for now. Thank you so much for listening and have a good day.